Shirish Alurkar sir to speak on systemic management of medullary thyroid cancers.
Good evening. I am the odd man out in this, that's me, okay. In this audience, in the august audience of surgeons. Can I know how many medoncs are here, medical oncologists? No hands raised, okay. So that makes my work easy because what I'm going to tell you is a very basic thing. A lot of it has been covered by the previous two speakers. So basically it's a treatment of advanced medullary thyroid cancer. The systemic therapy part, I will not talk of course on the surgery part. And the criteria, and this has been covered with MTC basically has been 5% of all the primary thyroid neoplasms, and RET always is the predominant mutation which we are looking at, and specifically the M198T type of mutation, but that is the mutation which is very sensitive to the drugs which I'll be mentioning in the next subsequent slides. And about 60% of these would be having the RET mutation. So we really have to look for the RET mutations in patients with medullary carcinoma. My work is very easy because I'll be talking only on 4 drugs which are approved. They have been mentioned by the previous speaker. Out of this, only 1 is available in India. So I think you can forget the other 3 drugs. They are mainly for the academic purposes as of today. So the overall survival in MTC, in advanced cases, if it's metastatic less than 40%, so there is a lot of thing to be done on this this subset of patients. And these are the criteria, correct me if I'm wrong, these are based on the American Head and Neck Society. They have defined various criteria for what they call advanced thyroid cancer, and these patients could be probably amenable to systemic therapies, which what I'll be mentioning. But of course, if you have some dynamic surgeons in the crowd, probably they can even remove these tumors in this subset of patients. So this is a very common algorithm which was again shown by the previous speaker. So as soon as you have a diagnosis of MTC histologically and it is not operable, then there are 2 drugs, one on the left which is vendatinib and the cabozantinib. Now vendatinib is unfortunately not available in India, so we only have to focus and do our modifications in medical oncology on one drug, that is cabozantinib. And if there is a progression on this, then we look for a RET mutation. And if there is a RET mutation, as again mentioned previously, we have these 2 drugs of selpercapitinib and you also have pralsetinib. Unfortunately, both of these are not available in India. So this is again a slightly more extensive algorithm. I'll not go into that. So these 2 drugs are the multikinase inhibitor. The last one is available based on this trial. And this basically summarizes my whole talk. The cabozantinib, the second drug in the white row, is basically it's a phase 3 trial, a good number of patients, 2:1 randomization. Locally advanced MTC, about 200 patients versus 100 patients. The endpoint was PFS, which was achieved with a hazard ratio of 0.28. So about 72% reduction in the chances of progression if you use cabozantinib in advanced cases. However, the overall survival, which we as medical oncologists are more interested in the OS, you surgeons are more interested in R0 resection. Our endpoint is overall survival, so that is what we are more interested, but it did not really fulfill the criteria. The other two or three drugs are there, but they also have shown some PFS benefits, but not really translated into OS advantages. A colorful cartoon diagram, this is all we can show as a medical oncologist. You people have a lot of colorful red colored fields of surgery to show, but we can't show. We have multiple colored fields, and basically this is the thing what medical oncologists are concerned. It ultimately boils down to the intracellular or the molecular level, and there are different pathways where all these drugs possibly act on the cancer cells. Toxicities are common. Fatigue is one of the common things. So usually when the patient is on cabozantinib, we have to dig deeper into the patient's history and ask whether he is really tired or not, or getting tired. That's very important to highlight. The 2 drugs, although they are approved by FDA in 2020, they are not really available, and they are mainly used after progression, say on cabozantinib. Again, the results are shown here. Same toxicities with the same drugs, less of diarrhea, less of skin toxicity, a little more of fatigue. So we really have to play with the fatigue and the hypertension in these TKIs. Seemingly small single tablet drugs, but they do have a lot of efficacy, but they have a lot of bearing on the quality of life of the patient. So I think that's all. I think I'd finished before the bell went. Thank you. Yes, please.
At cancer patient is having a metastasis, multiple metastasis. We had done the red analysis on tissue and we had found it is positive. You have options of selpercatinib and cabozantinib. If you have both available, which is your first choice?
So Selper is if you read Selper is better because more specific for a RET mutation. Cabo is a more wide spectrum, and Cabo will require again you specifically the mutation I showed, the TMT198. That's the main mutation with Cabo really works better.
How much is the rough cost of selpercatinib?
I have not used it.
Okay.
I'm not.
I would like to call on stage Dr. Samit Chopra and Dr. Akshat Malik for a group photo.